Hi, I'm Steve Charles. I'm going to talk to you about macular evaluation before cataract surgery. I'm a consultant to Alcon and receive a royalty, but it's not relevant to this presentation. Small incision refractive cataract surgery, a femtosecond laser, wavefront technology, intraoperative aberrometry, and particularly new technology, IOLs, and marketing have dramatically raised patients' post-op visual expectations. There's, of course, substantial evidence in the refractive cataract, the surgery community, on refractive surprises. However, what if the patient has a perfect refractive outcome but has disappointing vision? If you've discovered macular disease before cataract surgery, informed the patient and managed it, you're okay. However, if the macular disease is discovered after cataract surgery, the patient believes it's a surgical complication. Why do we have these visual surprises? Inadequate preoperative evaluation, suboptimal view because of the cataract, insufficient trainage knowledge or emphasis on macular disease, fragmentation of care, possibly an OD examined the patient, but the cataract surgeon did not, obsolete OC technology and display choices, and the fact that many critical macular diseases are simply invisible without spectral domain OCT. Vitreomacular schisis, vitreomacular traction syndrome, subretinal fluid on occasion if it's from a small CNV, central serous chorioretinopathy, transparent epimacular membranes, outer layer macular holes are simply invisible. You can't see them on fundus exam. So you don't examine the fundus to determine if they need an OCT. You do an OCT and then examine the fundus to learn a bit. Very small macular holes and the metamacular holes are occasionally invisible. Subretinal fluid, invisible on the fundus exam. Macular schisis, as well as outer layer holes, invisible. A small patch of edema secondary to an aneurysm, microaneurysms, invisible. A macular hole, suggestive on the clinical exam, but again, not obvious. If you had two posterior subcapsular cataract, you'd miss it. Vitreomacular traction syndrome, absolutely invisible. A fair amount of edema and subfoveal fluid, however, looks almost normal in the fundus epimacular membrane, normal. Fundus exam. So how should we do macular examination? We still do biomicroscopy. Of course, use a 78 and 90 diopter lens. Contact lens with anti-reflective coating is better, but they're inconvenient, rarely used. I rarely use angiography. It's certainly nothing you'd ever use for pre-phaco screening. And the Optos and Claris and other wide-angle visualization schemes simply have inadequate resolution for macular evaluation. Blue light autofluorescence is wonderful for geographic atrophy and previous CSR, except most cataract surgeons don't have this technology. So spectral domain OCT in every patient, not premium IOL patients alone, is absolutely necessary. Every single patient needs an OCT. It's part of the exam. Common OCT mistakes, old technology, pseudocolor algorithms. Don't use color algorithms, thickness maps, or 3D rendering. They hide crucial pathology. It's very bad to let a technician or photographer select a single image to put in the electronic medical record. Oftentimes, only one slice will tell you the story, and all the other slices will be negative. So the surgeon should look at all grayscale B-scan OCT slices, not a single image. Thank you so much. I hope this is helpful.
All right. Thanks very much for those two excellent talks. And we have, for our final panel, we have panelists Steve Charles, we have Priya Gupta, and Nathan Radcliffe. And so I thought I would start, Nathan, with the refractive surprises in patients on topical glaucoma meds. Did you attribute that to basically ocular surface disease interfering with the keratometry as the source of that error?
I think that is a big source of the error. I think we just also have this variable anatomy, like relative anterior microphthalmos, is common in glaucoma patients with angle closure. We have long eyes. We're dealing with a different animal in glaucoma. So I think you have two things. You have, topical therapy causing MGD and dry eye, interfering with biometry. And then you have challenges inherent to glaucoma patients that you're never going to really be able to eliminate. So you might as well go after the low-hanging fruit of the surface while planning your surgery.
And for the pseudoexfoliation patients, do you think it's zonular weakness affecting effective lens position?
I think it has to be. You know, I don't, the other thing though, keep in mind, exfoliation is more severe. They're always going to be on more drops. So their surfaces, you know, are worse off too. And I'm still not convinced that exfoliation syndrome doesn't cause dry eye just inherently, because they always seem to have it worse. You know, it's hard to know, chicken and egg.
Yeah. And if you could paint for us sort of the portrait of the EDOF candidate who's a glaucoma patient versus the multifocal IOL candidate who has glaucoma. A lot of surgeons who are not glaucoma specialists but encounter glaucoma patients, they're trying to decide, can I get away with an EDOF lens in this patient? Can I get away with a multifocal? Is it strictly foveal sensitivity that you're using, or what would be a general acceptable candidate for those two categories of lenses?
Yeah, I mean, there are two age, but then there is also disease velocity, and age is part of that. You know, we know that glaucoma accelerates over time. So in younger patients, even if they seem early and even if they aren't progressing, it's time to be conservative. And I think that, you know, the EDOF is your more conservative pathway. And I would also say with the multifocal lenses that now that these are the patients where everything is pristine. You have high confidence in, you know, the quality of the surface. You have high confidence in your measurements, and probably a more forgiving personality in the patient. So I think it's nice now that you have sort of a spectrum of options that you can fit to the patient's risk profile, disease velocity, disease stage, and ocular surface.
A question for Steve Charles. So a lot of cataract surgeons encounter patients who have comorbidities like epiretinal membrane. And so there's this quandary: do I have the membrane peeled first? Do I take the cataract out first? What would you counsel anterior segment surgeons in that regard?
If they have 1 or 2 plus nuclear sclerosis, I recommend doing the membrane peeling first, giving them a month to stabilize. Their visual acuity will stabilize over 18 months because of Stiles-Crawford effect, which is not measurable. You can't see it on OCT or even adaptive optics, but their refractive error will stabilize over about a month's period. If they have 3 plus NS, or 4 plus NS, or posterior subcapsular cataract, then cataract surgery should be done first, and the cataract surgeon should be counseled to measure with low coherence interferometry. So they measure from the RPE, and ultrasound is useless because you measure from the first reflection, which is an elevated macula, and you'll get axial length error.
And how do you feel about EDOF and multifocal lenses in patients with mild epiretinal membranes?
It depends a little bit on if the game plan is to remove the membrane at some point. These membranes are not chronically progress over months and months and months and years. They progress over about a month and stabilize. Surgeons that tell a 2040 patient, well, it'll get worse and then we'll operate when it's 2080. That's not what happens. These are not progressive disorders. So make a decision on the first visit what to do. And if you're going to membrane peel, then they're okay. We've had multifocal lenses put in these patients. But if you use ICG staining, which fortunately the use is waning with the approval of Brilliant Blue, the acuities are better, and so the patients will enjoy the use of a multifocal IOL. I guess the best way to say it. One thing, just you didn't ask me, I want to mention, I am absolutely opposed to phaco-vit, combining phaco-vitrectomy. It's done all the time outside the United States, and they have no regard for the refractive outcomes. They're ridiculous. And so it is absolutely better to have a cataract specialist like the folks on this presentation do it right, and have the retinal specialist do it at a separate procedure at a separate time.
So, Steve, another question for you. It's my clinical impression that vitreous floaters in these multifocal IOL patients and to some extent EDOF lenses, that vitreous floaters are much more of an issue. Can you comment on that in what you see in referral?
I absolutely agree with that. Vitreous floaters are not opacity objects, they're phase objects. So they impart in the region of the floater the kind of aberrations you talked about that the cornea induce. So if you realize that there's only 1 or 2% light absorption by a floater, there's a tendency to sort of minimize their visual impact. We have trouble seeing them because we're looking through the cornea and the lens twice. They're looking directly through it. And so in fact, multifocal patients, because the decreased contrast are much more trouble, particularly after YAG capsulotomy with floaters. Capsule materials and lens epithelial cells and cortex floating around the vitreous cavity are a huge nuisance to patients with MFIOLs or EDOFs.
I mean, it seems like the vitreous is the weak link in the optical chain in some cases.
No question.
And it's really tough for us as anterior segment surgeons because we have a patient who comes in complaining and they have a multifocal IOL, and we're wondering, is it their lower order aberrations? Is it their higher order aberrations? Is it their capsule? Is it the vitreous floater, or some combination thereof? So that's a real challenge for many of us.
And because OCT is a reflectance, it uses phase to measure difference, but it's a reflectance technology. It doesn't help you either. The infrared picture in the Heidelberg often will show you floaters, but areas of edema look about the same as the floater. So there's really no way to quantify them at the moment. One side story I want to mention, just take 1 second, is that we heard so much about the ocular surface, and appropriately so, in listening to patients. Patient after patient comes to me and says, it's kind of blurry. I said, does it get better when you blink? And if it does, it's not the macula.
Good point.
Good point. We had an audience poll question, actually, which I think I'm curious to hear what the panel is doing as well. But are you getting an OCT in all of your cataract evaluations or just in your premium patients? What are you guys doing? About half, the poll results are showing that about half of our docs out there are getting an OCT on everybody.
That means the other half's wrong.
I'm a big advocate of this, and one of my pet peeves is when people work up glaucoma and scan the nerve and then leave the macula out of it. You know, why? Because you wanted to save 3.5 seconds at the OCT machine. Always get both. Maybe not every time, baseline, get both. Every time, no exceptions. And yes, I wouldn't take a cataract out without knowing what the macula or nerve looks like, but the nerve we get a better sense of, I think, by visual inspection, whereas the macula just surprises me all the time.
You know, I think it's a little bit like when we used to encounter surgeons who were doing cataract surgery without topography. And once you use that on everyone, the idea of not having OCT of the macula and the nerve is really horrifying because there's so many things that you simply cannot find on clinical exam, especially the macula.
Yeah, I agree. There's newer devices out there. I actually just used the foveal snapshot on the IOL Master 700. So, and there's other swept source OCT biometers that are out there that can actually kind of in one step integrate that for you just from a practice efficiency. You know, most of the pathology that we're caring about is within the fovea. And I actually use that sort of as a screening for my staff. Like after they get the biometry, they'll look at it. And if they see something funny, then I'll tell them, you know, go get a full OCT before the patient comes to my exam chair. Because once the patient's already with you, you want to have a streamlined discussion. You don't want to have to go back and decide if they have an ERM that's, you know, meaningful, etc.
Well, I think it's time for us to wrap up this part. Those were really excellent talks. And I really want to thank our course directors, Kendall Donaldson and David Chang, who thought up this course pre-COVID and then pivoted to make it a virtual format, along with Carrie Braden, who really put together a fabulous program for us today. And there's a lot of work that goes on behind the scenes to make this happen. So now we have this breakout room session where you can ask the experts. You'll have the opportunity to join one of 3 breakout rooms to interact live with our faculty for about 15 minutes or so, maybe a little bit longer. And the buttons to access that post-event Q&A are going to pop up just above the video window in the next 30 seconds or so.
And our 3 breakout rooms, we have tips for managing refractive patient personalities, and that will have Dr. Dell, Hovannessian, and McKee. The second room is eyes with challenging corneas and external disease. That will be myself, Dr. Shami, and Dr. Holland. And then last but certainly not least, pearls for ocular evaluation and IOL selection. That will be facilitated by Dr. Trattler, Radcliffe, and Charles. So we thank you. The breakout sessions will be followed by an exciting non-CME event that's hosted by Alcon. And it'll start promptly at 1:15 Eastern time. There is a link that was sent to you by Ascaris yesterday, and additionally today. That session is moderated by Dr. Carrie Solomon, and faculty include Neil Desai, myself, Dr. Hovannisian, and Dr. Elizabeth Yu. We're thankful for their generous support of this meeting, and we're thankful that all of you are here learning on a Saturday, and we hope that you learned so many practical pearls to take back to your practice. I think I can speak for all of the faculty here that we each learned something new and exciting to bring back to you. So thanks for joining us today.